So this session's going to be on poison and overdoses, and I'm going to turn my camera off because my internet's not great. So just give me a second. So through the talk, if you can, I'll be asking quite a few questions, and if you can put the answers into the chat, that'd be really good, just to make sure, like, make it interactive. And for poison and overdoses, it's quite a difficult topic. I know that there's a lot of information that we're going to go through. I'm not going to cover obviously every poison and overdose, because you can, as you'll be able to see, you can poison and overdose on a lot of things. So don't be overwhelmed, and when you do get the slides, there's more slides at the end as well for you to go through in your own time. So first of all, we'll just go through the definition of poisoning. So administration of excessive amounts of a pharmaceutical agent, but a poison may be a drug, household product, industrial chemical, plant or animal derivative, which basically means you can overdose or poison on honestly anything. And there's a very high prevalence. So I've been in A&E for about 7 months now, maybe 6 months. And I'd see a few a day of people coming in with different sort of overdoses or poisonings. And I'm in an adult-only emergency department, and it's not just adults. And 2% of toddlers actually are in that database, and you get nearly 609,000 tox-based entries every year, which is a lot. So on examination, they're not always conscious when they come in. They can't tell you what's going on. So the first examination you need to be aware of is the Aoe assessment. So this is pretty much basics in all of emergency medicine, is the Aoe assessment. So A, are they maintaining their own airway? And do you know any signs of obstruction of an airway? If you just put your answers in the chat. Yeah, not able to speak. Yeah. Yeah, exactly. So snoring, stridor, cyanosis, gargling, they're all excellent, signs of obstruction. So it's not just unconsciousness. They can be sort of conscious, but struggling to breathe, accessory muscles, shortness of breath, exactly. And then other signs on your Aoe assessment is the rest rate. A high or low rest rate can indicate different things, and we'll go through them later. Circulation, your pulse, blood pressure, peripheral perfusion, all other good signs. Disability, so GCS is an excellent indicator. BM, a lot of different drugs can raise or lower your BMs. Any seizures or evidence of seizures, pupil reactivity and size, and then their temperature as well is also a good indicator in any other injuries. BM is your blood glucose, so your bedside blood glucose measurement. In the history, so if the patient is conscious, if they're able to talk to you, what sort of things do you want to ask them that's not necessarily for a history, but specific to poisoning and overdose? Yeah, what have they taken? Was it planned? How much? Staggered? Yeah. What with? Definitely. How much? What time? Yeah. Anything else that you want to know? Why? Yeah. Intention. Other medications, so symptoms now, alcohol with them too, brilliant. So there's so many different questions that's different to a normal history. So you want to do a risk assessment. A risk assessment is really important because you want to know whether it's accidental, deliberate or unusual, but there is a chance, prescription error. Is there a risk of it happening again? So if they're fine currently, but you send them home, are they safe for themselves? And then are they safe with themselves or others? So any thoughts of hurting themselves or others, and if they've got any children at home that could be at risk as well. And then age and weight is also really important because that can help with any of your antidotes that we'll go through in a bit. Past medical history medications, someone mentioned that, also useful. Other factors, if they've got any kidney or liver problems that they already have, so even if it's a small dose that they've taken, small-ish overdose, are they more susceptible to the complications? What was taken, so was it over the counter, illicit? Did they use alcohol at the same time, because that can change the effects of it? Ask about what they took, staggered, like you said before, and route as well. So inhalation, injection can put you at risk of lots of other different things, not just the overdose. So injection, so obviously risk of bloodborne diseases and that sort of thing. Review of systems. So a top to toe, anything, what sort of things do you want to know in your review of systems? Because medication overdoses can give you so many different symptoms. So what sort of areas do you want to cover? Cardiac, yeah. Renal, resp, CNS, vomiting, resp, pupils, yeah. Yeah. Yeah, exactly. It's basically any system you can think of you want to ask about, basically, because they can get any sort of symptoms. So seizures, dizziness, falls, so that's CNS. Changes in their vision, dry mouth or lots of saliva, so cholinergic sort of medications can cause these changes. Shortness of breath, chest pain, new cough, signs of heart problems, new respiratory issue. Abdominal pain, so vomiting, diarrhea, constipation, taking medication, even if the overdose wasn't massive enough to cause sort of heart CNS problems, they can irritate the GI tract too. And urinary aches and pains and rashes, just literally everything you want to know. And tox base is the most useful thing. So there's so many overdoses and you can overdose on so many things and their effects are different and they cover a lot of different systems. Tox base is really useful because there's an app and you use your NHS email, or if you're in a hospital trust, they have their own login. But it tells you which medication, you type in which medication and it comes up with symptoms to expect, what treatment you need to give, and when to start escalating and worrying and that sort of thing. And it is really useful. So most UK hospitals that I've been in, which is most of Merseyside now, have had tox base. I'm not sure about everywhere else, but it's a very useful app to have. But it does take up a lot of data, so I wouldn't use it until you're a junior doctor. So, first question. A person has presented within 1 hour of ingestion. What can you think? Any medication, they've ingested something. What is really useful in a lot of different medications? Yeah, brilliant. Activated charcoal, that's great, yeah. So activated charcoal is really useful. It works with most medications that you ingest. Obviously, check on tox base that it'll work for that one. But if you give them activated charcoal within an hour of ingestion, it can really help to absorb that medication so that it doesn't begin to affect the system. It doesn't get absorbed into the system. Naloxone is interesting, but not for any medication. That's one for one specific, but we'll talk about naloxone in a bit. So, first case, a 15-year-old female has taken 20 paracetamol tablets over the past 4 hours, but nothing else. Does anyone know sort of the grading for severity in paracetamol overdose? As a clue, it's in milligrams per kilogram. Yeah, fab, well done. So that's right, 150 milligrams per kilogram is sort of very severe, so there's likely to be some sort of after effects from over 150 milligrams per kilogram. And the possibility is, yeah, exactly, 75 is threshold for treatment because there is a chance that they will be have toxicity and complications, so you need to make sure that you're treating them still as well. And can you work out what this young lady has taken? Yeah, it's 500 milligram tablets. Yeah, so 222 milligrams per kilogram is how much she's taken. So she's taken a large overdose and has serious toxicity. Do you know what symptoms she'll be feeling currently? Yeah, nausea, vomiting. Yeah, so it's a bit of a trick question because she might not actually be feeling anything at the moment. So under 8 hours, there's a chance they'll be getting the nausea, vomiting, abdominal pain, but they might not actually have any of these symptoms, which often means that people don't actually present to A&E, which is a risk because if you're feeling okay and you've taken this overdose and you regret it, then you think, oh, didn't work, never mind, and that sort of thing. But it's actually important to raise awareness that if it's less than 8 hours, they still need to attend A&E, because things can get worse. And 2 to 3 days later, you can begin with hepatic necrosis, so liver failure, jaundice, kidney injury, raised LFTs, exactly. So it's really important that if it's less than 8 hours and they feel okay, but they're taking quite a lot, that you still manage them the same as you would with someone with severe symptoms. So the treatment, what is the treatment for paracetamol overdose? Yep, everyone's saying NAC, well done. NAC is N-acetylcysteine forbiate, and it binds to the paracetamol and removes it from the system. So a fun fact about NAC is that if it's given within 8 hours, it's almost 100% effective. So it's really important that you see and treat them as fast as they come in, okay? So if it's less than 1 hour, activated charcoal. If it's more than 4 hours, then you take paracetamol levels. However, if it's less than 4 hours, you can check the other bloods, but don't take paracetamol yet, because it can cause you to go in the wrong direction, because the paracetamol won't have been absorbed into the system completely yet. So it's important to wait to the 4 hour mark to check your paracetamol levels. And then you follow a nonogram, which I'll show you on the next slide. But there's different guidance. It's a bit confusing, but the hospital I'm in currently has a proforma that you literally follow. It's like a flow chart, step by step. And I'm assuming most places would have one as well, because I've seen it a few other places. It's a big booklet, and if you're in A&E, have a look for one just to have a look through. But you need paracetamol levels, UNE, LFT. You want to check the INR to check the liver functions, and the VBG. If it's over 18 hours, don't start NAC yet, and wait until you get the blood tests back. So you want to see what paracetamol levels are in the system. And then if it's a staggered overdose, it's a little bit more difficult. So I've put in the flow chart here, and you can have a proper look at it later, but it shows you the staggered overdose. You're going to start NAC pretty much anyway, because it's very difficult to work out how much they've taken milligram per kilogram wise. And this is the nonogram on the left of the screen, and the treatment line is this red line. So depending on how long after the overdose is and how much paracetamol is in the system, you treat depending on that. So you give NAC if you are over that treatment line, and you plot it on the graph. But again, the paracetamol proforma has it. And the dose of NAC is, the first one is 150 milligrams per kilogram in 200 mils of 5% dextrose over an hour. And then there's 2 more, like someone said before, 3 doses of NAC. So, yeah. The next slide is a 31-year-old male. He's found stumbling around the street, not making any sense. On arrival in the ED, the patient's drowsy, struggling to form sentences. A, his airway, he's snoring. Breathing, his respirate's 13. Blood pressure is 90/70 and heart rate's 44. And his SATs at 86%. His pupils are equal and reactive but sluggish, and he's got nystagmus. He's got 4 packets of a medication in his pocket that I'm not going to tell you yet, and his temperature is 35 degrees. What are the big red flags in this case at the moment? Yeah, brilliant. So basically everything is a red flag currently. You're all right. So heart rate definitely is bradycardic, it's hypotensive. His respirate's actually okay. His respirate's fine at the moment. He's not alert, he's snoring, his SATs are low. So I've highlighted all of the bad things. His temperature's also low, parasympathetic, that's good, and nystagmus too. So any idea what he could have overdosed on? This is a tricky question. So I've put this in to sort of be a trick, just to show it's really difficult to actually tell. But because his respirate is okay, it's unlikely to be an opioid, because that's going to cause respiratory depression, and his pupils aren't pinpoint either. So think of the system. So his systems have been reduced. So tricyclics is not quite. Benzodiazepines, yeah, fab. So he's actually overdosed on a benzodiazepine. I always think of it as depression. So benzodiazepine, usually it suppresses the nervous system, and this is over suppression. So his airway is blocked because his CNS isn't working. He can't stay awake. He's got nystagmus, and his bradycardic, his blood pressure's low, and his temperature's low as well. So everything's a bit lower, but not his rest rate. And with a benzodiazepine overdose, you have to be quite careful because it can cause rhabdomyolysis. So you need to make sure you add on a CK to your normal sort of test results. So anyone know the treatment for a benzodiazepine overdose? Yeah, brilliant. Everyone, it's on flumazenil. Brilliant. So flumazenil fluids and keeping him warm. So it's basically supportive treatment because flumazenil can work, but it's not great. So you can give it and see. That is a little picture of a bear hugger over a dog. For anyone who doesn't know what one is, it's just a hot air thing that warms up the surrounding of the person to keep them nice and warm, or the dog if you're at the vet's. And ventilation is only required in severe overdoses. So if they're not able to maintain their own airway and the flumazenil's not working yet, you need to ventilate them and intubate. But there is a caution with flumazenil because it can lower your seizure threshold. So if you're on other medications that do that too, any tips to remember flumazenil? I don't know. The only one is benzodiazepine with lots of Zs, and flumazenil has a Z in it. That's the only way I can remember, I'm afraid. That's my way. Hopefully it works for you too. And with flumazenil, you need to be quite careful with patients with epilepsy because, again, it can lower your seizure threshold. So it's just something to be aware of and to document if you do make the decision to give it anyway. So moving on to tricyclic antidepressants. So what examples of a tricyclic antidepressant do you know? So yeah, amitriptyline, clomipramine, yep. Imitramine, yep. Sertraline, I think, is an SSRI. But yeah, so another way to think of them is an anticholinergic because they'll have the similar effects. But I've done it as anticholinergics, but yeah, amitriptyline, nortriptyline, clomipramine, diazepam. So these are all examples of tricyclic antidepressants. There are also some other anticholinergics that would have the same effect if you overdose on them. So I've put them here. So it's sort of antihistamines, carbamazepine, phenothiazine, and oxybutynin. They're a strange group of drugs, but if you think of anticholinergics and how they work, it sort of helps to make sense of the symptoms that people would get if they did overdose on them. So in A&E, I've seen quite a few amitriptyline overdoses, and the people really do turn up with these symptoms. It's not one of those textbook things. So people are tachycardic, hypothermic, they've got dilated pupils, warm and dry skin, urinary retention, and agitation. So it's all of this activation of the parasympathetic nervous system. And they also get some ECG changes. Can anyone spot the ECG changes on here? It's tricky. Don't worry if you don't get it. Yeah, exactly. So the only one I've highlighted here, I don't think there's, I think the ST elevation is sort of because the QRS is prolonged, but I've circled some prolonged QRSs. The QTC is also long, but basically it's not quite VT yet because it's not long enough, the prolongation, but that is a risk in amitriptyline overdoses and anticholinergic overdoses going into VT because it causes these ventricular dysrhythmias. The normal distance, the normal length of a QRS is less than 120 milliseconds. But if it's higher than 100 milliseconds, you start to worry that it is a bit prolonged and you need to be more careful. And the risk of going into VT is when it's over 160 milliseconds. So it's very small, the difference. And it just takes time looking at ECGs. and measuring them carefully to see if they are prolonged. But again, all of these changes are in tox space, so you don't need to worry exactly. Like the ECG changes are important, that you notice that it was wrong, but the specifics you can check in tox space. What's the management of an amitriptyline overdose? Yeah, basically supportive and sodium bicarb. So there's not really an antidote. They say IV sodium bicarb is an antidote, but it's not great. Like the other antidotes, like flumazenil, it's not excellent. So you want to monitor the cardiac output with a monitor. Reassurance, yeah, definitely. It's a very distressing state to be in. Cardiac monitor is really important because they've got that risk of going into VFVT. And then IV sodium bicarb and intubate if things are very severe. If not, you need to, like you said, supportive measures. So treat the side effects. So seizures, give midazolam, hypotension, give fluids, and arrhythmias, bicarb, lidocaine. It's one of those ones where you just kind of have to wait it out, and a lot of the time, if in the severe overdoses, you intubate until the side effects have settled, and then you extubate. So next case is an 87-year-old female. She's had recent D&V in a nursing home. She's suddenly become very drowsy. She's got muscle twitches and pinpoint pupils. Is there anything else you want to know about this lady? Yeah, brilliant. So normal medications, respirate, medical history, allergies, yeah. Fab. So her Aoe assessment is she's got a reduced respirate, reduced SATs. She's sedated pretty much. She's got meiosis and bradycardia. Regular medications, she's on ramipril, atorvastatin, bisoprolol, Longtec, Oromorph, midazolam, and metformin. Past medical history, she's got type 2 diabetes, high blood pressure, she's had an MI in the past, and she's got breast cancer and bony mets. So what do you think she's overdosed on? Yeah, so far. So Oromorph, yeah, she is an opioid overdose. She's got all the symptoms. She's got reduced respirate, pinpoint pupils. She's got these muscle twitches, which I've actually seen a few times in people. They're sort of spasms that they can't control, and it's the effect of an overdose of opioids. So this lady has had a D&V, and because she's old and frail, it's caused this AKI. So it's quite it's a relatively common cause of an opioid overdose in very elderly people. Their kidney function gets knocked and they're no longer excreting their morphine. So then they are actually overdosing on their normal level. So what is the treatment? Yeah, fab. Naloxone. So giving naloxone it depends. It's a sort of tricky one. Naloxone is an opiate antagonist, so it completely knocks out the opiates from the system there and then once you give it, and it's got a really short half-life. So there's a lot of chance of sort of the naloxone wearing off and the person will go back into overdose because they've not had enough time for the naloxone to clear. That's a good question. So you wouldn't give naloxone, you would still give naloxone if she was an addict and her respiratory rate was reduced and she had a reduced GCS, because there'd be a risk of this person going into respiratory arrest and being very well and intubating. But you need to be a lot more careful with naloxone in people who are chronic users, because they're used to a baseline level, and if you knock out all of their opioids out of their system, they'll get exactly rebound. And sometimes in people who are chronic users sort of for pleasure, they actually become very aggressive and agitated and are quite dangerous to themselves and to others in the department. So in that situation, a lot of people would give an infusion, so to slowly reduce the amount of naloxone, slowly reduce the amount of opioids in the system, rather than give them the big dose straight away and get it out of them. So that's just something to be cautious of, but you would never be expected to start a naloxone infusion without any sort of senior help. So for the basics, do you know the Well, that's the answer to the question. Yeah, so 400 micrograms is the first dose of naloxone. And then if that doesn't work, or it works but they go back into sort of opioid overdose, then 800 micrograms is the next. Then you take a minute. If that doesn't work, another 800 micrograms. And if that doesn't work, 2 milligrams and then 4 milligrams. I've highlighted those in different colours because at this point, yeah, as paramedics, you give the naloxone definitely if they're in a point where they're about to go into respiratory arrest. So 2 milligrams and 4 milligrams you wouldn't be given in the department to somebody much more senior than you. This is a medical school final sort of thing. But 400 micrograms is the dose to know, and then double it for finals. And then infusion. So next case. It's a family of 3. They've come into A&E. They all have similar but very vague symptoms. They've got headaches, nausea, vomiting. They're dizzy and weak, and they're all a little bit confused. What are your differentials? Yeah, 5. You've all got it. Anything that you would need to consider if it's not carbon monoxide poisoning? Yeah. Gastroenteritis, flu, but it's carbon monoxide poisoning. You're all right. So there is a bit of a stupid acronym. They're in the NICE guidelines, and it's the one that they tell everyone about, but it is COMA, and it's with carbon monoxide poisoning. I'm not going to make you guess because it's a bit of a silly one. I don't think it actually works that well, but because it's so silly, you sort of remember it. So C stands for cohabitees. O is, do your symptoms improve when you go outside? M is, when did your appliances, sort of your cooker, your grill, last have maintenance? And A, do you have a functioning carbon monoxide alarm? So it's a bit of, they've sort of squished it into this acronym, but because it's so silly, I sort of remember it. What is the management for carbon monoxide poisoning? Yeah, exactly. It's just oxygen pretty much. One thing that is quite useful to know is that you can measure the level of carbon monoxide in the breath test. So that's a good way. If you're not sure if it's carbon monoxide, you can do a breath test. A lot of places have them. Yeah, the CO monitor for smoking cessation. Yeah. So people have different levels. So smokers have naturally higher levels of carbon monoxide in their breath anyway, but there's different cutoff points. So I think it's less than 3% is normal. And that changes whether you're a smoker or not a smoker. So you measure that immediately because those levels reduce the second you leave the environment where the carbon monoxide is higher. And you need to check there's no other family members in the house, so make sure they've not left like an uncle in one of the rooms, because they're at risk of becoming very unwell. You need a blood gas. It's sort of, you don't kind of have to do it because if you're suspecting carbon monoxide poisoning, you suspect their PO2 to be normal. So VBG may be fine, as you can see, metabolic acidosis. But if you're not sure, an ABG will be useful because if they've got a deranged oxygen, it's probably not carbon monoxide poisoning. And then 100% oxygen, you need to give as much of it as you can. So you want a tight fitting mask with an inflated seal. Neuro exam's important to see their baseline because a lot of people get prolonged neuro symptoms afterwards. And then supportive, and in very severe cases, definitely hyperbaric chambers. Yeah, tox base. Well done. It's a great database. When you start work, just use it. And thank you for answering all of my questions. If you've got any questions for me, just let me know. There's lots more slides after this, so if you fill in the feedback form, you'll get the slides and you can go through them later. It's quite a long session to go over, so thank you.